So, dear all, thank you for joining for this new episode of the ESD School. And today we will target a greener endoscopic resection. I mean, an endoscopic resection with less carbon footprint and less impact on the environment, which is one of the most important topic we should deal with for the next generation. There is no doubt now we are going straight to the wall, and all the impact of human beings about the environment leads to a climate change which is clear and for the moment always increasing with more and more consequences every day. So the consequence of this is that we cannot skip environment and climate change in all our decisions, and we should also think about it when we choose a strategy for a patient, and when we do something for a patient, we should do it effectively with the less impact on the environment. So first, the environmental footprint of endoscopy is very high. It means that each endoscopy procedure leads to around 2.1 kilogram of waste, which is 46 liters, and it means that for a unit like mine, every week we send a full truck of waste to the incineration, so we should probably think about it and reduce it. The packaging is the most important. The contaminated part is only 28%, and the recycled part of the waste is only 9%. If everything was disposable, we will increase of 40%, and if we use single-use cup, it will be multiplied by 4. So there is a statement from ESD that is to reduce our environmental impact and think about green endoscopy everywhere for every situation. So where are we now? In the UK, the part of medicine health in the full process of carbon footprint is 5%, 8% in France, and endoscopy is the third bigger polluter with 3.1 kilogram of waste per patient and per day of inpatient in the hospital. So first, we should reduce. How can we reduce? So first, to show you the impact of a procedure, this is the result of our randomized trial RESEC colon that compared piecemeal EMR with ESD, and after we did a post-hoc study about the environmental impact of the two strategies. And when you see the procedure itself, it is around 63 to 73 kilograms of CO2 equivalent per procedure. The transport of the patient is 1/2 of this. And if we add the follow-up, we will increase it again. And we will increase it more if we have a lot of follow-up, needing the patient to come back to the hospital many times, than if we do a single shot, one procedure that treats the patient curatively. So first, what are the environmental impact of our procedures? The devices are an important part of the procedure, but the main impact of what we are doing in the hospital is the patient transportation to the hospital. And yes, it is different from one country to another country depending on the access to public transportation, but in our country, more than 80% of the patients are coming to the hospital for getting cares by car, by own car or by health taxi or health ambulances, but it's 80% of them that come with a fuel car in the hospital, leading to 1/2 of the carbon footprint of all the management of the patient. And if we consider the carbon footprint, ESD, for example, has a little more impact than piecemeal EMR because the devices are a little more complex, the duration of the procedure is a little longer, the intubation rate is higher than in the piecemeal EMR. So as a procedure, ESD is more impacting than piecemeal EMR, but if we add the follow-up that is more important in case of piecemeal resection than in case of R0 resection in one time, we will invert the ratio, and ESD becomes less impacting than piecemeal EMR because you reduce the number of colonoscopy needed at 6 months, 18 months to deal with an eventual recurrence after piecemeal EMR. So first, and it is probably the most important, the main key point is that we should not resect a lesion if it's not relevant. If it's not relevant because there are criteria of invasive carcinoma, I mean large area of 5N or SANO3B pit pattern, stricture on the tumor, ulcer on the tumor, all those cases should not be resected by endoscopy because it's a kind of endoscopy for nothing, because we will go to surgery and we take risk for the patient instead of sending him directly for the extension checkup and the surgery. And the second point is for a benignant lesion to think about the comorbidities of the patient. If the patient has a very low life expectancy because of many diseases, heart, lung, anything, we should not resect the lesion which is benignant, which will take years before being a cancer. But the patient is very severe on the comorbidities, and we will not bring any advantage to him by doing the resection. Second thing is to reduce the fossil fuel transports. One way to reduce this is to reduce the number of time the patient come to the hospital. For example, to explain the procedure, to explain the risk, we could do it virtually with telemedicine instead of asking the patient to come 3 times. One to explain the procedure, one for the procedure, and one after to give the results. Probably the surrounding parts could be done with telemedicine instead of coming. And when they come for the procedure of resection, in my center, the total trip to come to a resection is around 175 kilometers. It means 80 kilometers for each transport. If they come by train, it's 0.1 kilogram of CO2 equivalent. And if per kilometer, instead of coming by car, which is the double, it means for such a transport around 34 kilogram of CO2 equivalent. And same for explaining the result of the procedure after getting pathology, telemedicine is probably enough. Second thing, we should also reduce the distance to find a good resection, a resection with a high level, whatever the technique. I mean, if the patient will undergo piecemeal EMR, it should be done by very experienced guys that are able to reduce the rate of recurrence and do it properly. And for this, we should probably develop the training and try to cover as much as possible the territory. It's the example of the French ESD training. One of the main points to select the candidates every year is to cover the territory and allow patients to benefit from ESD everywhere on the country. Next, we should also reduce the number of follow-up colonoscopies. And the best way to reduce this follow-up is to be R0. It means with no risk of local recurrence. With piecemeal EMR, even if the risk of recurrence is low thanks to thermal ablation of the margins, it remains, and for the moment it's impossible to skip the 6 months and 18 months follow-up, and therefore if you choose a resection with a R0, you can skip 6 months and 18 months and reduce a lot the carbon footprint of the whole process of treating the patient, because you will reduce the number of time he has to come back to the hospital for a colonoscopy. So once again, choosing R0, whatever if it is in EMR or in ESD, but getting a R0 resection is better to reduce the impact. There are another benefits of being R0. It means you will have a better pathological assessment, a reduction of recurrence, and a reduction of the need of follow-up. So all is going to be better with R0 even if it has to be associated with a good morbidity ratio. We should not take risks which are very high compared to piecemeal EMR just to be R0, but we should try to be R0 as much as possible if safety is maintained. In this example about ESD versus EMR piecemeal, you can see that the procedure was 73 kg of CO2 for ESD, 63 for piecemeal EMR, but the follow-up due to the non-R0 resection was 83 compared to 8 kg if all the follow-up are done in the expert center that did the first resection. And it becomes very high footprint if you have chosen piecemeal EMR with all the follow-up in expert center, with quite the double compared to ESD with a one-shot treatment that cure the patient without risk of local recurrence. So how can I increase my en bloc and R0 resection? In EMR, it can be done by using underwater EMR, for example. It reduces the number of local recurrence, it increases the number of en bloc resection, and the rate of perforation is not higher. So using underwater EMR is a good way to improve the en bloc and R0 resection rate without decreasing safety. Next, here, one important thing also in the randomized trial is that the T1 cancer rate was higher in the ESD group than in the piecemeal EMR group. That could be due to a loss of information because of piecemeal EMR. So once again, getting the good pathology to know exactly what is the tumor of the patient and reducing the risk of recurrence, 0.6 and 0% if R0 instead of 5.1 after piecemeal EMR and thermal ablation without any predictive factors is a good way to reduce this. So ESD could become both a safety net for all the lesions to be sure of the pathology, but also to reduce the recurrence rate and the need for follow-up. Next, we should also develop the treatment if possible, close to the patient. So for endoscopic resection, like piecemeal EMR or ESD, usually in France, the patient are sent to an expert center. But after, the follow-up to detect the recurrence could be performed in local center to reduce the transport of patient. And if you do all the follow-up close to the patient, I mean in a local center, the ratio about carbon footprint is reduced with 95 for piecemeal EMR with all the follow-up in local centers and 76 for ESD if the follow-up that are needed for R1 resection are done locally. So you can see that passing from everything resection and follow-up in expert center to resection in expert center and follow-up locally reduce a lot the ratio of carbon footprint. And last thing, if you do a simple resection, I mean piecemeal EMR in local center and the follow-up in local center, you reduce a lot the carbon footprint with something which is close to the carbon footprint of ESD in expert centers and follow-up in local centers. So if we add a good piecemeal EMR resection with very low risk of recurrence locally in local hospital, it could be equivalent on the carbon footprint to ESD in expert center and follow-up in local center. But for the moment, it has never been demonstrated that piecemeal EMR done locally without systematic thermal ablation can lead to the same result as the published one in expert centers. Furthermore, when you have a recurrence, you should introduce a new treatment, sometimes a dedicated additional colonoscopy for treatment if the recurrence is complex, and it increases again the follow-up because you will have to do a new colonoscopy 6 months after the resection of recurrence. So dealing with recurrence is not so easy, even if recently David Tate showed that most of the recurrences small in size can be treated by simple means in expert centers. It does not always need EFTR or ESD. So finally, ESD increase the R0 and reduce the recurrence. And if you choose piecemeal EMR, thermal ablation is very important to reduce the rate of recurrence and therefore reduce the need for dealing with recurrence and the carbon footprint due to these recurrences. Can we skip the early follow-up after EPMR with thermal ablation? I don't think so. In our study, it was 5% of recurrence after PCMR and 0% of the lesions were excluded from the analysis. In Australia, it's 5% in the first study in 2019, 1.4% of recurrences in a recent study, but with 4.6% of failures of thermal ablation where the follow-up was maintained. So around 5% of patients that should be followed up after. And in the US, even after thermal ablation, the rate of recurrence was 13% in this recent study. And fourth point, how can we reduce waste during the resection itself? And we will discuss about strategy to reduce the carbon footprint, devices to reduce, and other points. So first, we can choose economic strategy or strategy adapted to the difficulty of the lesion. What is needed for ESD is a scope, a cap, and a knife. And sometimes you will need more, I mean hemostatic forceps, needle to inject, and traction devices. But it's not always mandatory, and sometimes in easy case, it's easy to do a simple strategy. We know that without traction, the speed which is reached is around 15 to 25 square millimeter per minute. With simple traction, 35. With multipolar traction, 45. With adaptive traction devices, 66. And therefore, if you have a very large lesion where duration is very important, we should use traction. It's easier, and you will manage to do the resection thanks to traction. Same thing if you are not so experienced in ESD. You will save time and you will achieve more success thanks to traction than if you don't. But on the opposite, when you are experienced and if the lesion is very easy or very small, it's also possible to do a resection without any traction to save clips, to avoid dealing with many devices and many wastes. So once again, we should probably adjust ourselves. A very simple resection can be done with a small amount of devices, but if it becomes complex, you will save time and therefore reduce the carbon footprint of anesthesiology, for example, thanks to devices of traction that increase the speed and increase also the rate of success. So my strategy will be that very easy cases, semi-pedunculated lesion, when the gravity is okay, when the lesion is under 3 cm, I do sometimes ESD without any traction. When it becomes to be more difficult, simple traction is always used for me. And once we reach more than 4 cm lesion, and when I know that it will be difficult because there is a fold, there is a difficult access to the lesion because it's a little blind or something, I will use adaptive traction to have the most effective traction I can get and be sure of the success in a relatively short duration. Second thing, the devices. If possible, using only one scope instead of 2 scopes, one for diagnosis and one for treatment, will reduce a lot the impact. One scope reprocessing represents around 10 kilograms of CO2 equivalent and 60 to 80 liters of water for every resection. So when it's absolutely needed to have 2 scopes, one for the good diagnosis and one for the treatment, it's justified and we should use 2 scopes. But if it's not needed, it's a very big impact to use 2 scopes instead of one. Second thing, if we use a 2 knives strategy, like it was described at the beginning, with 1 needle knife for the initial incision and an insulated tip knife for tracting during the procedure, we increase a lot the impact economically and also on the waste point, because for every knife we have around 100 grams of waste due to just to the form, the user form of the device, and a second device to produce. So it's another benefit of the single knife strategy is to reduce also the impact economically and on the climate change. So as much as possible, using one knife is probably the best strategy. Second point, injection, for example, in the rectum is feasible with the knife itself. You do just a small hole and then you inject into the area. It will inject a lot and in the good layer with less hematoma. It's not possible to do it, for example, in the esophagus or in the right colon because the wall is very thin. But in many cases, it's possible to use the knife as the injector from the beginning, avoiding to use a needle and therefore avoiding also to use devices that are not absolutely mandatory. Once again, it will represent a cost reduction and also a climate change reduction of the carbon footprint. Next, the forceps for hemostasis is not always needed thanks to the new technologies of seeing the vessel flow with, for example, red dichromatic imaging like here. It is sometimes possible to obtain the hemostasis thanks to a precise coagulation with the knife without using a second devices like a hemostatic forceps. So once again, by being more precise, trying to see and to detect clearly the bleeding point, we can also reduce the number of devices we use and the need for hemostatic forceps. Last thing, when a traction is used, because we need a multipolar traction, for example, if you use a standard single-use clip, it's around 86 grams of waste for every device. But if you use reloadable clips, like this one, there are one which is not rotative with Olympus, but there are no rotative ones that are reopenable from Creo, for example. You have a single-use handle of 78 grams, and each clip additionally represents a 4 grams waste. So in the case where you want to use 5 clips for traction and 5 clips to close the wound, it will be a lot of difference of waste at the end if you use reloadable clips compared to single-use one. So once again, using reloadable devices will also reduce your carbon footprint. Second thing, by organization planning, we can also reduce the impact. In our unit, it's possible when we have several colonoscopic ESD in the morning to use the same flushing tube and the same injection tube for several procedures if we use devices which is an anti-reflux valve like this. If we add this thing that does not allow any reflux from the device to the tube, we can use the tube for different patients. and therefore we do it. And for example, if we do only one colonic ESD in the morning, we will reach around 4 kilograms of waste for one patient. But if we combine several colonic ESD in the morning for patients with one part of the devices that are shared for the different patients, we will reduce the weight of waste at 2,200 for each patient. It means quite reduction of 2 compared to only one ESD in the morning. And other point, we should also reduce our transport footprint as a physician. It means using remote virtual medicine instead of moving for the patient, but also for us, and encouraging public transportation, walking, or making advantages for the patient to take the train. Second thing, for the training itself, for being trained in ESD, we should probably encourage remote training with virtual training. That's why we developed this ESD school on YouTube instead of doing a lot of lecture when we have to move by flight everywhere. So we wanted to share our experience in ESD to most of the people without moving, being able to stay at home. And when we have the real practical technical skills training, we should encourage people to come by train and choose a facility where it's quite easy to come. And the other point is probably to discuss a lot about the training itself, because using living animals for this training is more and more difficult, at least for me and for people who are really sensitive to animals living. And in the literature, in this study, even if people prefer living animals to be trained, it's not absolutely mandatory, because we can also have a very good progression in ex vivo bovine colon, for example, without sacrifice of living animals. So once again, we should question our practice and try to reduce our impact by reducing the number of training on living animals and trying to find substitute of this thanks to isolated models or even to non-animal models. But for the moment, the non-animal models are not very good to discriminate the progression of trainees. And to summarize about this green resection topic, the resection should be justified. The patient interest should be our main question. Is it interesting for the patient on an oncologic but also on a personal point of view when they have a lot of comorbidities? We should target a curative resection and, if possible, R0 resection in order to reduce the number of follow-up. We should question the patient about life expectancy and reduce the resection for people who have a lot of comorbidities. We should increase our R0 rate. When the patient comes to an expert center, ESD R0 will reduce the number of follow-up, will reduce the number of recurrence, and will increase the quality of pathological examination. And for the patient also, it will improve the comfort to reduce the number of bowel prep. We should reduce the transport by training people everywhere on the territory to reduce the transport of patients to come to an expert center. So we should cover the country. Develop telemedicine for all the things that don't need a direct contact between the patient and the doctor. And we should encourage the train transportation instead of fuel car. We could be more economic by reducing the number of scopes, devices, choosing the good strategy adapted to each difficulty, and keeping traction for all the difficult cases to reduce the duration of the procedure, but probably being able to do conventional ESD when it's very easy and when we could save some devices. The training should be reasonable and responsible, and developing virtual training is one of our objectives to reduce the need for moving everywhere by flight to get trained. And finally, ecology should be considered in every choice, at least for our children. And I show you two pictures of my two main motivation in life to reduce my impact and try to fight climate change. Thank you very much, and hope it was interesting for you, even if it's a different topic from usual, and hope that you will consider to think about ecology and reduction of our carbon footprint for every choice, every strategy, everything in medicine like we do in our current life. Thank you very much. See you.